Well, welcome, everyone. Are there Renaissance men among us? Well, how you will call a person who carries out research in science, medicine, and engineering? How you will call a person who is a chair professor of anesthesia at Harvard and chair professor of medical engineering at MIT? And in addition, practicing anesthesiologist in Massachusetts General Hospital. How you will call a person who, in addition to all these academic responsibilities and work, also runs an outstanding MIT neuroscience statistic research lab with 5 to 10 postdocs and over a dozen of undergraduate and graduate students from engineering and medicine as well. How you will call a person who has been elected to the National Academy of Sciences and National Academy of Engineering and National Academy of Medicine? How you will call a person who received numerous national and international awards, the most prestigious ones? The recent one is the Schwartz Prize in the area of theoretical and computational neurology. How you will call a person who has his undergraduate degree in applied math, master's and PhD in statistics, and medical degree MD, all of them from Harvard. Ladies and gentlemen, I'm very happy to present to you Emery and Brown.
Oh, wow. Well, thank you very much for that tremendously kind introduction. And it's a real pleasure to be here to participate in this distinguished seminar series. It's an honor for me. So thank you very much for inviting me. What I'd like to do is I'd like to talk about some of the work that we've been doing in trying to rethink general anesthesia. So I call this Rethinking General Anesthesia Systems and Computational Neuroscience. So before I begin, I just want to make some disclosures. These are the funding sources that we've had the good fortune to have, and there's some commercial interests that are associated with some parts of this work. I just want to mention down at the bottom there. These are my colleagues that I've had the good fortune to work with: Patrick Purdon at Mass General Hospital, Nancy Goppel is a mathematician at Boston University, Shuna Keju, anesthesiologist at Mass General, he's now our department chair, Ken Salt at Mass General Hospital, anesthesiologist, Laura Lewis, who's now in the faculty at Boston University, she was one of our former graduate students, Ahmad Eskandar, neurosurgeon, who's now at Einstein, Sid Cash, neurologist at MGH, and Shenung Cheng, who's one of my former postdocs, who's now a professor, associate professor of electrical engineering at WashU. So this is the outline I'm going to follow you. I'm going to tell you a little bit about anesthesia by telling you something about anesthesia's slow delta oscillations. I put in brackets this work on multimodal general anesthesia because if we get to, I'll talk about it last. I want to talk about closed loop control of general anesthesia. I also want to talk about reanimation. So that is turning the brain back on after anesthesia. That is waking someone up. So let me begin. So what is general anesthesia? So it's this drug-induced reversible state that consists of antinociception. That means you've blocked out the ability to process pain information. You're unconscious. There's amnesia. You can't form any memories. You're not moving around, so it's easy for the surgeons to operate. And you do this while maintaining physiological stability, all right? And it's a reversible state, as I said. You bring the patient into it, at the end, you bring them out. Now, it's often said that how general anesthesia works is a mystery, and nothing could be further from the truth. And I'll just give you the 2-sentence summary. How does it work? Well, what happens is the drugs create oscillations, and these oscillations impair the ability of the various parts of the brain to communicate. All right, so, and I'm going to show you that, several fold in the next 45 to 50 minutes. And so I'm going to start talking about these anesthesia slow delta oscillations. And so just for those of you who are not familiar with some of the neurophys terms, a slow oscillation is going to be something from about, a slow delta oscillation is something from about 0.1 hertz up to about 4 hertz or so. But I want to begin with a little bit of history. So these is a schematic of some experiments that were done back in 1935 by Frederick Bremes. So Bremes is a Belgian neurophysiologist, neuroscientist, and he did his experiments in cats. So in the first set of experiments, he severed the spinal cord, separating the spinal cord from the brainstem in the brain. And then he measured the EEG in the cats. And what he saw was this pattern here, which he called the encephale isolé, the isolated encephalon. And it looked like an awake appearing EEG. All right, looked very irregular, desynchronous as it's called now, but it looked awake. Then in the second set of cats, he made a transection here in B at the level which separates pretty much most of the brainstem and the spinal cord from the brain. And he called this the cerveau isolé, isolated cerebrum. And if you look here, now he saw these very slow delta oscillations. And so what we've come to learn from these experiments, there's something in this part of the brain here, something here, and sort of like going from, like the part of the midbrain in the pons and down to the upper part of the medulla that has to do with arousal. And so now we know that the arousal centers are there. So when you inactivate this part of the brain, what do you see on the EEG? You see slow oscillations. And this is what I'm going to call Bremes Principle. And the reason I'm going to call it that is what I'm going to show you is I'm trying to put in place a paradigm so you can understand what the anesthetics are doing. All the anesthetics produce slow oscillations, but they do it from different mechanisms because they attack different targets in this brain region here. And that's going to be sort of the topic of the first part of my presentation. All right. So to do this first, let me give you a sense of what anesthesia really looks like. So this is an EEG. I'm going to show you the EEG of a woman that I took care of a few years ago. She's about 60 years old. She weighs about 80 kilograms. And I'm going to give her a bolus dose of propofol. So propofol is our most used anesthetic. It's the one that was associated with Michael Jackson's demise. And I'm going to give her a bolus dose, and we're going to watch how her EEG changes in real time. So this isn't edited. So I'm going to give her a bolus dose of about 150 milligrams and inject it. So I just went ahead and injected it. Now, the first thing you're going to see, there are 4 leads. So these are on the front of the head, the 2 on the left side of the forehead, 2 on the right. And what you're going to see here is the EEG is going to get very noisy here. So you see how it's getting noisy there? See that noise? And that's because when you inject propofol into a vein on the back of the hand, a small vein, it burns like crazy. So that's her tensing up and, tensing her arms up, right? Now that's actually going to be good from a pedagogical standpoint because you're going to see exactly the moment when the drugs take effect. Watch right here and right now. Watch this. So the beta oscillations, look at that. Now there come those large slow oscillations. She's unconscious now. They get deeper. And now she goes flat and burst and flat and burst. All right. So let me show you what happened to her. All right. So this is her awake up here in A. So this is about 5 microvolts. So it's very low amplitude, sort of high frequency oscillations. This is the way our brain is most of the time when we're awake. All right, we'll skip over paradox excitation. Now here's the state that I just showed you where I said, watch where the beta oscillations come on. So these are beta oscillations. They're between 12 to 16 cycles a second. If I were giving her anesthesia so that she could maybe have just a colonoscopy where she needed sedation, I would titrate the EEG to this pattern here and sort of keep it there. It's obviously a lower dose of anesthesia. But she went right from here down to E. You started seeing those very large slow oscillations. So if we start applying Bremes Principle, that should tell us that that's some effect in the brainstem. We don't know where yet, but some effect in the brainstem. And then you saw her go into this very deep state of anesthesia here where she was flat and bursting and flat. And between the burst period, she was basically isoelectric like this, all right? So these states from here, we'll come back to D. These states here from D through G are states of coma. In other words, you see these same patterns in patients that are in states of coma. So it's one reason we can think of anesthesia as a drug-induced reversible coma. And the other thing I want to point out is you see how this is about 5 microvolts here. As you move down to these oscillations here, the ones that are associated with being unconscious, they're about 20 to 50 microvolts. And we'll see in the kids, they can be as high as 1,000 microvolts. So you can see the drugs cause this very, in this case, propofol causes very dramatic transformation from being in this state here, low amplitude, high frequency, down to essentially high amplitude, low frequency oscillations. And this is what the state of unconsciousness looks like. So let's dissect this a little bit further for propofol. So if we're to look at this in the frequency domain and we plot it as across time, you'd have a plot that looks like this. So this is maintaining maintaining an infusion of propofol, not just the bolus, but an infusion. So you started here. So just to orient you, this is time on this axis, this is frequency on this axis, and the color tells you the frequency content and how large the amplitude of the oscillations are. And let me just go back here for a second. Right here, this is, sorry, this right, I'm going to look at this pattern here. So if you look at this pattern here, which we skipped over, you see it has low frequency oscillation, a slow oscillation, slow delta oscillation, and it has a higher frequency oscillation riding on top. All right. So that's what we're looking at here. So after the slow oscillation, after she got the initial bolus of propofol, this is a young woman I took care of a few years ago. Now what happens is she goes into a pattern which has a 10 hertz oscillation here, so 10 cycles per second. At the same time, she has the slow oscillation. And the reason it stays there is we're maintaining an infusion of propofol. So we have this sort of dual oscillatory pattern that's occurring, all right? And then you turn the propofol off and it disappears and she wakes up over here. So, and this isn't an enhancement or anything like that. If you look at this in the operating room, it looks just like this on the monitor. It's a very, very strong signal, a very, very strong signal. And in fact, I'll go even further. It's the strongest EEG signal there is of all the things the EEG is used for, whether it's to track sleep, track patients in coma, to look at behavioral studies or cognitive studies. The EEG under anesthesia is the strongest because you saw it. We have large parts of the brain, as we're going to see, which work in concert. And moreover, once the drugs take effect, you saw it happen in the video, the noise disappears, the movement artifact disappears. So it's a very clean signal. So if we can't use the EEG to study or take care of patients under anesthesia, and it really can't be used for anything else because we have the cleanest signal. So now just a little bit of the neurophysiology. So propofol works by enhancing GABAergic inhibition. So it works at interneurons. And these interneurons are all throughout the brain. So the cortex down here in the thalamus, on in the brainstem, and also down in the, going down to the spinal cord. So they're everywhere. So propofol literally hits all of these various regions. So the 10 hertz oscillation that we see here, we believe is an oscillation going back between the thalamus and the cortex. And we've done work looking at this in non-human primates as well as in rodents. So we've done sort of modeling work on that. But what I want to concentrate on for the moment is the slow oscillation here. And by Bremes Principle, there should be some targets in the brainstem which are responsible for it, at least contributing to it. It's not the whole story, but it's part of the story, an important part of the story. And if you look right here, this pathway that I've drawn out in red lines here, this is the preoptic area of the hypothalamus. This is a major inhibitory network, and it's GABAergic. And so propofol works by enhancing GABAergic inhibition. So it's a very important inhibitory neurotransmitter in the brain. And so you have synapses here on all these sites. These are those arousal centers, right? So this is that area of the brain that I was referring to when I showed you like Bremes' diagram there. And so here are the targets that propofol could hit. And the postulate is, based on what Bremes showed us, that part of what is occurring when you apply propofol like this is it's taking out these very important inhibitory pathways. That's part of the explanation for why we get the slow oscillations coming up here on the cortex, like we see here. And the other part is there's actually direct action on these interneurons here, which enhance their inhibition. They inactivate these pyramidal neurons, these excitatory neurons, and also here in the TRN of the thalamus. So the TRN, it's called the reticular nucleus of the thalamus. It's really not a nucleus. It's like a net. It's reticular. It's like around the outside of the thalamus. And this is a very important, obviously, control center in the brain. So when you take out the excitatory inputs going up to cortex from here, you take them out from here, and you're actually blocking them here. These are the major components of what we see in the slow oscillations. So, but the first part we can understand with Bremes' principle. I want to go a little bit further. So this is just me conjecturing, showing you this, and this is then looking at a diagram and sort of making some arguments. I want to show you just a little bit of experimental data. And so this is human data. And these are from an example from a patient who has epilepsy that has grids implanted so that the grids and strips so that the neurosurgeons and neurologists can figure out where the epileptic foci are. This is a patient who's failed medical therapy and now has to come for likely resection of an epileptic focus. So they get these electrodes implanted. They stay implanted for about 5 to 7 days. The person is allowed to cease off of medications, and they come back to have a resection, have an explantation to remove the electrodes, and then to subsequently have a resection. So what's nice about this with, our colleagues, like I said, Sid Cash and Ahmad Eskandar, they're interested in doing research also, in addition to helping to take care of the patients. They were able to record spikes here and also LFPs, local field potentials. And this is work which Laura Lewis published back in 2012. This is part of her PhD dissertation. And so you can see here's the local field potentials being recorded when the person's awake. And look at the neurons. This neuron here can spike wherever it wants to. So this is a neuron which is sitting next to this red electrode. Now look what happens when the person becomes unconscious and you have these large slow oscillations. So now the neuron can spike here, spike here, spike here. So there's almost a 2-second gap between each of the spike events. And so this is this is like these what we call up-down states. So you can imagine this is like the neurons. In other words, if the membranes are basically hyperpolarizing sort of grossly across the entire cortex, then it's going to be much more difficult for the neurons to spike. So these are the down states here, and these are the up states. It's just a matter of polarity, how you represent the electrodes. But what you can see here is there's a very limited window where the neurons can spike now. So this is what's happening when we see the slow oscillations. Now I'm showing you this for this human subject here, but we've been able to go a little bit further with this and look at this in non-human primates. So this is work we just published last year with my colleague Earl Miller, very well-known cognitive neuroscientist and non-human primate neurophysiologist. And this was work done by Jacob Donahue and Andre Bastos. And so here's the same thing, looking at this in a non-human primate. So these are 4 brain areas. So 8A, so like the frontal eye fields, the prefrontal cortex, the posterior parietal cortex, a little further back. And this is the periotemporal gyrus. This is the auditory area. And so this is the local field potential that you see here. So the animal's awake, so as I saw before, like low amplitude, not very much going on, sort of desynchronous activity. And here's these parts of the brain. Here's the spiking activity going on in the corresponding areas at the same time. So a lot of spiking activity, quite dynamic. And to give you some quantitative feel, the spike rate here is about 10 spikes per second. All right, so it's spiking at about 10 hertz. Now let's look at it. So do the same thing like we did with the human. So here's the large slow oscillations, which have now come into play. And now look, here's the spiking activity. Now you see these large gaps occurring here, here, here. So these are the up and then the down states. And the down states are quite broad. And as they look here, they're actually quite coordinated across the different brain regions. And again, to quantify this a bit, the spike rates here, like I said, are about 10 spikes per second, 10 to 12 spikes per second. Now they're about 0.5 to 1 spike per second. So you've got something about on the order of about a 90% drop in spiking activity. So what you can see is that the slow oscillation is strongly coupled with a strong modulation of the neural spiking activity and also a decrease in the spiking activity. So this is certainly one of the mechanisms through which the drug is contributing to the person being unconscious. And then the slow oscillations here, that gives us some insight that there's at least some effect of this occurring in the brainstem based on Bremes Principle. Right. And just to take this a little bit further, this is showing, this is the Propofol data over here again. And this is some analyses that were done by one of my current PhD students, Josefina Carrera. So I'm going to show you time on this axis here. And so what happens is, this is us recording the animal at baseline across those 4 different brain regions. They're in a different order. I apologize for that. So PFC is down here. This is 8A. This is the prefrontal cortex. And this is superior temporal gyrus. So this is the spike rate. So again, you can see it's about 10 spikes per second. You can read the rates about 10 spikes per second in each of the regions. And right here, we start the propofol infusion, all right? So the propofol starts running, and look how the spike rate drops. And around here is when the animal sort of became unresponsive, what we consider behaviorally lost consciousness. And so then so the spike rate is dropping. So now we turn the propofol off here, and now the spike rate starts to come up, and the animal woke up over here, all right? So you can see how the spike rate dropped. And this is what I was saying. So this is about 10 spikes per second. This drops down to about a half to 1 spike per second when the animal's unconscious. So that's propofol. But I want to contrast that with ketamine over here, which is, we dosed a little bit differently. So for the same animal and the same brain regions doing the same sorts of recordings, you give them ketamine. So in a different experiment, all right, just to compare them, you have the baseline here, which is just like the baseline over here. And now when you give the ketamine, and again, a dose which can make the animal unconscious, look what happens. The spike rates here in all 4 brain regions are pretty much the same as they were when the animal was awake, but yet the animal is unconscious. So what you see here is you have a totally different dynamic between these 2 anesthetics, and that's what I want to explore a little bit now with the ketamine. So this produces a very large slow oscillation where the brain activity is actually turned off, and this is actually doing something different where the spike rates are just the same as when the animal's awake. So let's look at that for ketamine a little bit further. So this is showing ketamine here, and this is analyses that were done by Indy Garwood and Suresh Chakrabarty, graduate student and postdoc in the lab, who just published this last year. So this is a typical pattern of ketamine, and this is actually taken from a human subject. So this is the high frequency oscillation that you see with ketamine. Like when you give a dose of ketamine, a low dose, let's say around 30 milligrams, like around a half milligram per kilogram, 35 milligrams, you'll get this very, very fast oscillation at about 25 to 30 hertz. And this is the pattern that you see when someone hallucinates. It's also in the drug range that's given for using when ketamine is used for treating depression. And then when you look here, but look what happens. When you give a dose, which is now appropriate to make someone unconscious, you get the fast oscillation, then it becomes really slow. And then it goes fast and slow. And here it is in the spectrogram. So here's a longer segment of it, about 60 seconds of it. So look at this. So there's that fast oscillation, and actually has a downward chirp. It starts from here, drifts downward, then it goes slow. Goes back up here, starts up here, drifts downward, and slow. And it does this, the back and forth, the alternation between the fast and the slow is about every 4 to 10 seconds or so. You can actually see the pattern there. All right, so look, we're getting slow oscillations when someone's unconscious. And just parenthetically, let me just mention, ketamine is considered an essential drug by the World Health Organization, such that by that it means that if you were to go somewhere like a remote area to give anesthesia and for surgical purposes, and you could only take 1 anesthetic with you, take ketamine, because in addition to being able to make you unconscious, it also produces profound analgesia. Propofol wouldn't do that. Propofol can make you unconscious, but you couldn't use it to treat the pain associated with surgery. So it's a highly essential drug. So if we just look at the anatomy here, Bremes Principle predicts that there has to be some target here in the brainstem, which would be responsible for the slow oscillations that we see with ketamine. And so I've just drawn it out here. There are 2 very strong centers. So ketamine works by blocking what are called NMDA receptors, so glutamate receptors. So they're very, very prominent, 2 very prominent glutamate projections coming out of the brainstem. One is the median pontine reticular formation going to thalamus, the parabrachial nucleus also going to thalamus, and both of these projecting to the basal forebrain. So we can think of ketamine coming here, blocking this point here, and sort of like this is again a chemical version of what we saw with the Bremes diagram. So it helps us understand some component of why we get the slow oscillations with ketamine. Now the world isn't that simple. That's just part of it. And let me just go back to the fast oscillation. So that has a totally different mechanism. So you can see here, ketamine acts in the cortex. It acts on these inhibitory interneurons. So the inhibitory interneurons also have these NMDA receptors. So The interneurons are sort of, they're like, there's about one interneuron to about every 8 to 10 pyramidal neurons. So the interneurons are working like this all the time, opening and closing, opening and closing. And for ketamine to induce its block, it has to actually get into the channel and block the channel. So at low doses, probabilistically, it's more likely to get into the channel for an inhibitory interneuron. So as a consequence, you inactivate the interneuron. So the pyramidal neurons speed up. So that's why at low doses, you have just this part of the pattern here. And then once you give enough enough ketamine to actually affect both the interneurons and the pyramidal neurons, you have the much deeper effect, and you get this pattern here that goes back and forth between the two. So that's just a high level explanation of it. But before we started building any models of this, we wanted to do a more detailed characterization of it. And the way I have it showing it here, it looks like you go fast, slow, slow. But it turns out there's more complexity to the pattern than that. It turns out that the patterns actually coexist. So you can see here, you have periods where the oscillation is quite slow, here where it's faster. And then you have periods like here where the two are sort of coexisting. So what we did was, I should say what Indy and Suresh did, was an analysis looking at this using a sort of straightforward hidden Markov model. So here's time on this axis, and here you can see the two patterns. You can see the low frequency oscillations here, and here the higher frequency oscillations. And if I blow up a segment of this and put it over here, then they used a hidden Markov model that had about 4 states in it, excluding this sort of baseline state, which is just basically the pre-anesthetic state. And what they were able to show is you don't just go from slow oscillation up to high frequency, but you go through a set of transitions very, very systematically, where you have the slow oscillation with a little bit of fast, a little more fast, then it becomes sort of pretty much all fast oscillation. Then you drop back down, and you go through this in a very regular pattern throughout the course of the anesthetic course, as long as the ketamine is being infused. So this is an entirely different dynamic from what we saw with propofol, and it can't be explained just by simply saying that you have to work out the dynamical system model, and that's what we're doing now. This is one of the exercises that we're completing, but we can't get to the model until we have a detailed characterization, like I'm showing you here, of what the actual dynamics are. And here's just an illustration of the same thing, showing you that this is like across like the 4 cortical regions. So that these patterns are not happening just kind of randomly across the various cortical regions. So for here, 50% of the time, all the areas are basically totally synchronized. Almost 70% of the time, these two areas, superior temporal gyrus and PCP, are highly synchronized. Not surprisingly, the 2 frontal regions, the prefrontal cortex and 8A, the frontal eye fields, are synchronized more than 80% of the time. And this isn't a random, it's not a random phenomenon. So the dynamics here are much more complex than what's going on with propofol. But what you can see is becoming unconscious is not just turning the brain off. Becoming unconscious is changing the dynamics of the brain in a way away from the dynamics that you have when someone's conscious, and away from could mean slowing it down, like in the case of propofol, or in the case of ketamine, it means alternating between one state, which is really slow, and another one, which is really fast. So let me just say a couple words about nitrous oxide. About a year ago, Ezra Marcus came to call me up to talk about an article he was going to write for the New York Times. And this is the sort of the front page of that article, because he wanted to comment on the fact that there's been a resurgence in the use of nitrous oxide among the young people. And it's actually as a party drug. And it's like a very, very bad idea, because it could be lethal. And he read a paper that I'd written about nitrous oxide. And I told him that once I saw the patterns in the EEG, we published a paper about the oscillations that we see in nitrous oxide, I realized why this drug could like kill you within a single breath. And in fact, this is something that we actually do with kids. So for example, in young children, you can't put an IV in them very often. So you give them have them take a single breath of like sevoflurane or nitrous oxide and sevoflurane mixed together. And literally in less than 10 seconds, they become unconscious. Then you can start putting in an IV and going on with the anesthesia and on with the surgery. So the idea that a single breath could basically make you profoundly unconscious is actually something we actually take advantage of in the operating room. But so why might something like this kill you? Well, let me show you what the slow oscillations from nitrous oxide look like. This is like that same monitor like I was showing you for the woman in the video at the start of the lecture. So from here to here, each one of these, the spacing between these vertical lines is 1 second. So look at this. These are those 4 leads like that I showed you on the woman's head at the beginning of the lecture, and look at them now. They're like perfect sine waves. I mean, this is literally your brain on nitrous oxide. It goes in these extremely profound, large amplitude, slow oscillations that are highly regular, at least across the front part of the cortex. And you can see why this would not be a situation to be compatible with, efficient information transmission. And just to show you what it looks like in another setting. So one thing that a lot of my colleagues do is at the end of the case, they'll start nitrous oxide. They'll turn so this is isoflurane. So this is one of the ethers. It's GABAergic. It works very much like propofol for the most part. And so you turn the isoflurane down and you start the nitrous oxide here because it's easier to wake someone up from nitrous oxide than it is from isoflurane. And so once you turn the nitrous oxide on, you see how this oscillation here, this is the isoflurane oscillation up to this point. Now you see how it's starting to break up, it breaks up. Then all of a sudden, it really is just like an abrupt transition. You go to these very big slow oscillations, like right here. This is what I'm showing you. And what's interesting about this, and this is still a mystery to us, is that they come on abruptly, then all of a sudden, they just disappear. And you have these sort of fast oscillations here. It's like in a very abrupt sort of state transition. I have no idea why this happens, and it's very likely it's something that we may never really understand because of all the anesthetics that we use. Nitrous oxide is probably the most harmful for the environment. So the recommendations are to use it less and less, and we're certainly doing that. But from a neurophysiologic standpoint, it's like really, it's like fascinating. And again, because nitrous oxide blocks NMDA receptors, again, we can apply Bremes Principle and come with a very good idea about why those same sort of targets that ketamine was hitting are the same ones that nitrous oxide is probably working on in the brainstem, which would give us an explanation for why we have these sorts of slow oscillations. Now, I just want to mention one other drug finally, which is dexmedetomidine. And dexmedetomidine, very often people ask us, are there any of your drugs that produce states which are like sleep? And dexmedetomidine comes the closest. And you probably remember that in sleep you have these various non-REM and non-REM. And so within non-REM sleep you have 2 stages. So there's non-REM 2, non-REM 1, 2, and 3. And in non-REM 2 sleep, you have what looks like spindles. These are waxing and waning 10 hertz oscillations. And then you have slow oscillation at the same time. And then in this deepest state of sleep, slow wave sleep, you just have all slow waves. This is an emulation of that. This is actually dexmedetomidine. This isn't sleep. It has spindles like this, which are, again, you can see that these waxing and waning 10 hertz oscillations. And then you also have these slow oscillations here, which you can see the sort of the slow undulation here in the background. And then when you go to the sort of a more profound state of sedation, you see predominantly just slow oscillations. And again, invoking Bremes Principle. So dexmedetomidine is an alpha-ergic drug which acts presynaptically. And it acts presynaptically primarily at this projection coming out of the brainstem. So again, we conjecture there's some place in the brainstem where at least part of the effect resides. And so locus ceruleus here projects up to the basal forebrain. It projects to the preoptic area of the hypothalamus, to the central thalamus, and also just directly up to the cortex. And so by taking away this input here to these 4 main regions, you can start to postulate why you would see these sorts of large slow oscillations. So this is the closest anesthetic we have to approximate something which is like sleep. The other stages are either sedation, or if they're profound enough, they're actually unconscious, or you're unconscious, you're not in a state which approximates sleep at all. So I just want to make one final comment about slow oscillations. They occur in 3 other very important situations. In very young children, and very young means 0 to 3 months of age, if you give them propofol anesthesia or sevoflurane anesthesia, all you'll see are basically slow oscillations. And then over here in the elderly, in other words, we saw like for propofol and sevoflurane, you had like alpha oscillations in addition to slow oscillations. Older patients have just slow oscillations. And what we've come to appreciate that this is most likely just a byproduct of aging. If you think about a neuron, which has been around for, let's say, 78 years, the myelin sheath is breaking down, the dendrites don't extend and retract as much as they would, when the neuron was younger. The neuron is susceptible to oxidative stress. The mitochondria don't produce as much energy, and the neuron releases less neurotransmitter. So it makes sense that it would less faithfully transmit the information, which was being less faithfully transmit the information, through the brain in general. So this is one of the reasons why we think we see just slow oscillations in older patients, not just based on the neuroanatomy, not having to invoke anything having to do with Alzheimer's or degenerative diseases. And another very important case is an overwhelming sepsis. When patients have rip-roaring infections, even very young patients, you see these very large slow oscillations. This is a very typical pattern for someone in the ICU. And in fact, this is a pattern which was commonly seen. I mean, this slide I made before the pandemic, but this is a pattern you commonly see like in patients who are in the ICU, have rip-roaring infections, particularly like those who have COVID. And so this is probably a physiologic response, but we should think of it in terms of Bremes Principle also, because it turns out this is work done by Mark Ott, who's at the University of Washington, who's basically shown that the inflammatory mediators, actually, before I say that, when you become sick, when you develop the flu or what have you, you don't feel like running a marathon. I mean, you want to, you want to rest, or you want to relax. And so that's probably physiologic, because the inflammatory mediators, as Mark Ott at University of Washington in Seattle, showed that the inflammatory mediators bind to the arousal centers like in the brainstem and basically shut them down. And so it makes sense, again, with Bremes Principle, that you'd have slow oscillation, particularly if you had overwhelming sepsis. So these are three other cases where we also get these large slow oscillations, this is very important clinically. And so I put this up here because we've been trying to teach anesthesiologists how to use the EEG, like I've been suggesting here, to infer the states of patients under anesthesia. It's not something which is commonly done. Somewhere between less than 30% of anesthesiologists use the EEG to track patients' brain states during surgery. And even though we're required to monitor physiology, heart rate, blood pressure, oxygen saturation, CO2, we're not required to monitor the brain, even though the brain is the primary target of anesthesia. And this is something which we're hoping to change, and have anesthesiologists using it in a more informed way. So actually, I'm just going to skip over this. I want to get to closed loop control and reanimation. So if we understand markers of when someone's unconscious, it makes sense that perhaps you could build a controller to actually control that state. And so this is some work that, again, Jake Donahue and Suresh Chakrabarty did. And the idea is very, very simple. Suppose you have a marker of what it means to be unconscious. There's some spectral feature that I could actually follow. And as that spectral feature was in a certain range, I knew that the animal or the person was unconscious, right? And so you could set a target level for that. You could estimate what it is coming out of the EEG or the local field potentials. You pass that into a controller. The controller controls the infusion rate of the propofol going to a syringe pump. And then every 20 seconds, it updates it updates the infusion of the propofol. And then the cycle repeats, all right? So again, a very standard control scheme. And we've been doing this for about 4 years now in a non-human primate model, because the FDA has not approved any closed loop system for anesthesia delivery in the United States, because they said there's not been enough large animal testing. So we set up this non-human primate model. Again, this is a collaboration with Earl Miller, my colleague at MIT, to actually do this. So here's the insight that Suresh had. So he gave propofol, like a continuous infusion of propofol. And remember, I showed you that spike rates go down really, really low when the animal is profoundly unconscious. And what he found out was, just this is an empirical observation, the power in the 20 to 30 hertz band really tracks the decline in spike rate. So this is real unconsciousness. I think we would all agree that at the spike rates we saw 1 to 2 spikes per second, that the animal that I showed you was probably not conscious. And this is something we can use to track it or to create that state. So we're going to use this as the control marker because we know we're generating this state when we control this variable here. So now I'll show you this. So the control variable is going to be here. The infusion rate is going to be here. And the down here, you're going to see the arrow, and here's the spectrogram. So what Suresh is going to do, he has the target level set at 1. And what he's going to do first is just let the propofol run at a constant rate, because that's what we do in the operating room. We have no controllers helping us out. The propofol just runs at a constant rate. And then he's going to let the controller take over. And each segment's going to be about 30 between 35 to 40 minutes. So I'll just play the video. So it's at a constant rate. You can see in the middle panel, it's about 0.3, about 4 mils per minute. And then you see the markers going all over the place. It should be at 1, and now it's going down below 1, meaning the animal is getting deeper and deeper. Now the controller switch is on. And now it's holding the marker right at 1 where we want it to be. So what we're going to do next is we're going to take it up to take it down to a lower number, which means make the animal more unconscious. The controller just slips down and drops to a lower level, now down to 0.9. And now what we're going to do is going to make it less unconscious, going up to about 1.1. And the controller has no trouble doing that. I mean, no big surprise. But again, like I said, this is not being done currently in the operating room. And let me just show you something here, which is really important. So look, this is a constant infusion. This is something we see in the operating room all the time. When you run constant infusions of the anesthetic drugs, this teaches us something very important. The patients get to be deeper and deeper and deeper. So if you don't change your infusion rate in some sort of principled way, you're going to have a heck of a time waking the patient up. And look what the controller did. The first thing it did was it just turned off the infusion for about 3 minutes or so, let the system recover to the target level, then it popped back on. It did the same thing over here. When we wanted to get up to this level up here, it turned off for about 8 minutes or so to allow the system to actually catch up, basically with the target. I mean, if you told an anesthesiologist they have to turn their infusion off for a while, I mean, they would never do that because everything is sort of done blindly. You have to always have anesthetic going, but you can see that the controller is telling us something, teaching us something from this just very simple model, which was extremely useful. So this is something which we hope to perfect and eventually take and test in humans. So I want to leave you with this one final idea of reanimation. After anesthesia, what we do is we let the person wake up. We don't give them a drug to turn the brain back on. So brain disorders, cognitive brain disorders are very common in older patients. And you can see why, because if your brain has been sitting there oscillating like this for like the last hour, 2 hours, 3 hours, whatever, it's ridiculous to think that it's just going to pop back to its normal state, particularly in older patients. So we've been studying, I should say I've had the good fortune to work with my colleague Ken Salt on this at Mass General. And so here's an animal that's anesthetized with propofol, all right? And he has an IV running into his tail vein, so he's getting propofol. And Ken has an electrode in his ventral tegmental area. So this is the top of the midbrain, an important arousal pathway. So what he's going to do is he's going to turn the stimulating electrode on in a second. Watch right here. You can see as soon as he turns on the stimulation, watch what happens to the breathing right there. He starts breathing like crazy, first of all. Now, we didn't turn the propofol off, so whatever is happening is overpowering the propofol. And the rat just decides, I'm going to get up and get out of here. All right. Okay, so that's cool. So he's seemingly walking away, right? But is he really awake? All right. So Ken did another set of experiments. And these experiments, what he did was he had the rat, he had the rat learn a task. So what the rat does is it learns to make a choice, and it hits the correct choice, it can turn around and get a food reward. So then what he did was After he trained them on that task, he anesthetized the rat. He put the same electrode in the ventral tegmental area. And now he anesthetized the animal. Now he wakes him up by stimulating the brain, just like I showed you. Now the animal wakes up and is going to start working again. All right. And then Ken's going to let him work for a bit, and then he's going to turn the stimulation off. In this case, the sevoflurane is going to take effect again, and the animal is going to go out. So let me just show you this. I'll play the video for you. So there's the animal. He's basically anesthetized with this isoflurane. And so Ken's going to turn the stimulation on here. So the animal comes to. He looks for food, but he has to execute the task first. He's not going to get food with no reward without work. So he hits the light, hits the correct light, turns around and gets the food. All right. Remember, the anesthesia is still on. That's important to realize. The stimulation is driving his brain above the anesthesia. So he looks there, hits the correct light again. He's a little wobbly, but he's actually cognitively processing. He knows exactly what he's supposed to do. He turns around again, and I think he gets this one wrong. Turns around, looks there, hits the light. Okay, that light tells me he did it wrong. So he doesn't get a reward. Now, a few minutes later, after he's been practicing for a while, what Ken is going to do is he's going to turn the stimulation off. He turns the stimulation off, and animal freezes in his tracks. He's back anesthetized again. All right. So what is Ken doing here? So he's done this with Ritalin, so you can get the same effect of turning the brain back on after anesthesia with Ritalin. And it activates this pathway going from the midbrain here, so the ventral tegmental area through the limbic system up to cortex, a very important pathway for reward, but also a very important pathway for cognition, And so when people self-administer Ritalin, which isn't a good idea because they want to make their mind sharper, this is the pathway they're taking advantage of. But what Ken is doing here, he's stimulating this nucleus directly electrically. He's also done it optogenetically and shown that it's primarily the D1 dopamine neurons that are responsible for this effect. So he's stimulating this brain area here to wake the animal up. And then what's happening is when he applies the anesthesia and he stimulates it, he can overcome the effects of the anesthesia. And as soon as he takes the stimulation away, the anesthesia takes over again and makes the animal unconscious. So what have I shown you? I've shown you that the anesthesia-induced low delta oscillations are something we see in all the drugs for different reasons, and they represent probably these blocking projections coming out of the brainstem going to various parts of the cortex and thalamus, in addition to direct actions on the thalamus and cortex, showing you that each anesthetic has a different signature, and the signatures change quite a bit with patient age and sort of physiologic condition. I didn't show you the multimodal anesthesia, but I showed you the closed loop control and the reanimation. The idea that what we could do is turn the brain back on as a way to get rid of, to sort of bring someone back. And then in terms of maintenance, right, if the signatures are good enough to actually identify the brain state, then we showed you can use probably closed loop control to actually maintain a very accurate anesthetic state. And so my thinking is we should be using the EEG to monitor unconsciousness in patients who are receiving anesthesia. Again, I skipped over the multimodal, but that's a way of picking the drugs in a principled way. The closed loop delivery, as I said, is a way to titrate the anesthetics on a second-to-second basis to maintain an appropriate level of consciousness, just the right level, not too much, not too little, because you saw what happens when you have a constant rate. The level just gets deeper and deeper. And then turning the brain back on is a way to provide better anesthetic control, speed recovery, and hopefully prevent things like postoperative cognitive dysfunction. So I'll stop there. So thank you very much.
Hey, any questions here in the audience or on Zoom? You can chat the question or unmute and ask the question. Please go ahead.
Yeah, I have a question.
Go ahead. Who is that?
Yeah, this is Herb.
Okay, go ahead.
Herb Winslow.
Mm-hmm.
Yeah, with the anesthesia that most closely resembles sleep.
Mm-hmm.
Do patients report dreams after they after they awake?
No, not with this, because the part of this which is missing is the REM sleep. So most dreaming, not all, but most dreaming takes place during REM sleep. So this approximates the slow wave component. Then you go into the rapid eye movement, the REM sleep, and that's where you have most of your dreams. So these patients report being sedated, but not dreaming. Patients who receive ketamine, though, when they wake up, they'll report hallucinating, because it's a very very commonly used street drug for that reason. But the others don't report dreaming.
Okay, thank you.
More questions?
Well, there was one put in the chat. Who wouldn't want to use a better loop system such as this that would use less drug and better control?
You're preaching to the choir, right? I mean, it's like such an obvious thing, to do. And I think for me, the most compelling feature, I didn't pay attention to the simulation, and we were just so happy to get the results going. But the part where you have the open loop state, where essentially a constant infusion, that's what we're running in the operating room now. And I can tell you, once people get a level of anesthesia where they feel is appropriate, because they're not watching the EEG or anything, they just let it sit there. And so what's happening is exactly what you saw. The animal just went deeper and deeper and deeper and deeper. And you need a controller to come along and say, okay, let's cut this back and let's tune it up. So I just think this is a very obvious thing to do, which, requires, some effort to pull off. But now that we have these signatures, which we think help us understand a little bit better what the brain states are like, we see this being very feasible.
Exactly.
Let me ask a question. Thank you very much for this very interesting presentation. I was wondering if there are any differences in the frequency content between a species. The signals that you see, are the brain a function of these frequencies, or is it pretty much the same? And if it is the same, what is the source of that?
Now, that's a very good question. So for example, so we can look at them here. So this is kind of like, so here's a human and here's the non-human primate. So one of the reasons we're using the non-human primate is because the brain architecture and the size is a little bit closer to the human brain, much more so than the rat, okay, let's say. And you will see some species differences between, let's say, rat brain dynamics under anesthesia. They're grossly the same, but you will see some differences. So for example, when you look at like the alpha oscillations in rodents, they're quite different from the ones that we see like in humans. And they reflect to some degree architecture. Remember, so, at best for like a small, a good sized rat, the brain is probably barely like 3/4 of an inch or something like that. So you basically have this sort of very small packed network, which has some of the architecture that we have in humans, but it can actually be different. So those differences can reflect actual real anatomic differences between the species.
Thank you.
Mm-hmm.
I think BJ has a remote question. BJ, if you want to unmute.
I have a quick question.
Mm-hmm.
It's quite amazing to see how the animals can be reanimated. Is there a non-invasive stimulation paradigm that would it make the similar effects as opposed to directly innervating a specific brainstem nuclei?
Yeah, so the answer is possibly, you could imagine having something which may be triangulated from the outside and went and stimulated maybe like the thalamus or something like that. And the reason we know that the thalamus would work is that that's been done invasively in humans by Nico Schiff, very well-known neurologist at Cornell back in 2007. He published a paper in Nature showing that. So if you could non-invasively stimulate the thalamus, you'd probably get that arousal activity. And so the Ritalin idea that I just mentioned is something that my colleague Brian Edlow, now we did, or I should say Ken did these experiments in rodents showing to give Ritalin and get a very similar effect. He's actually trying it now in coma patients. developing, he has a protocol, which he's running now, a clinical trial, testing Ritalin as a way to help enhance recovery of patients that are in coma. So something along these lines, either pharmacologic or maybe non-invasively, would be possible.
Would it be possible to use vagal nerve stimulation?
No, because I mean, I shouldn't say that too fast because it's amazing how, how complicated the system is. So if you think of where the vagus sits, and then when you get these effects from vagal nerve stimulation, you're actually taking a retrograde transmission sort of up the vagus, right? I mean, they're mostly. So, but what you want to do is the arousal centers. That's why if you think about Bremes Principle, the arousal centers sit basically in the brainstem. And even though you're getting up to part of it, you're not really activating sort of the richness of the brainstem. So ideally, you should go to like a brainstem center. And I can tell you from having, we've done these experiments. If you stimulate any one of the major brainstem centers, the parabrachial nucleus or like perhaps the locus coeruleus, you'll get an arousal response like you saw in the animal there, like you saw in the VTA. So going more directly to the brainstem is sort of indirectly to the vagus. That's what I would guess.
Right. Okay. Thank you.
I think DJ as well.
Go ahead.
So thank you very much for the excellent talk. I had a quick question on the signature that you mentioned. How accurate or how noisy is that? I mean, I guess that's one of the, as an engineer or whatnot, I would be concerned about that. Would I always catch it? Would it be weak in some people? I mean, in the sense of how precise.
So this signal here that I'm showing, this guy here, right?
Yes, yeah.
So we've done this now across, non-human primate experiments are expensive. So we've done this now across like 2 animals, like with 9 sessions total, like in the animals with each session about, 2+ hours of control. And this works pretty well. And, we had no trouble controlling it. And the reason it works so well goes back to here. And that is every time you give a drug like Propofol, like I was showing you, you see exactly the same thing. You see very much the same thing in the slow, and the older people who see just the slow oscillations. So this behavior is very stereotypical, is what I'm saying. Now, clearly, it's nowhere near like controlling like the flaps on an airplane, because you design the airplane, you know about every feature of it. So we're doing some reverse engineering here with very low order models for the pharmacokinetics and the pharmacodynamics. But modulo that and the fact that you have signatures like this. And remember, the other thing I said is the EEG under anesthesia is the strongest signal there is for the EEG to begin with. So if there's anything you can probably control, it's going to be anesthesia as opposed to anything else.
Thank you.
It's not, it's not a deterministic system, like controlling airplane flaps or that sort of thing, but it should certainly be able, it should give us better control than what we're doing now, where we're just ignoring everything. That's actually the straw man, doing nothing.
Thank you.
Good question?
Dr. Brown.
Yes, sir.
This is Mayor Mirkov. Thank you so much for your presentation. I truly enjoyed it, and I'm very impressed with your work. I have one comment and one question. I think that your research can be probably applied in the ICU as well, because we do a very similar thing. We want to anesthetize or sedate a patient who's intubated and maybe profoundly ill, and we truly leave the propofol or Precedex at whatever set rate is. And yes, sometimes we titrate it based off of their kind of their RAS scale or whatnot, but we really do just leave it at some arbitrary rate. So I think it might be very useful in the ICU as well to keep people sedated enough, but allow them to easily wake for spontaneous breathing trials or whatnot. So I think that could be a very, very useful application as well. The question that I had was in regard to traumatic brain injury patients. I was wondering if you've looked at their brainwave signatures and see how they vary based upon their injuries. And then sometimes we use drugs like amantadine to try and promote their
arousal.
recovery. Exactly. And to see maybe how that affects their brain signatures.
Right. So Interestingly enough, even though my research is on sort of what happens to anesthesia in the brain, I'm not on the neuro anesthesia service. So I don't see a lot of these brain trauma patients myself, you know,
Yes.
like personally, but I can make some conjectures based on what I've seen here. So like when they get to the when they get to the ICU, they often have these very just profound slow oscillations, as you probably know better than I do, right? And
Yes.
so for one thing, it tells you that you probably don't need a lot of anesthesia to sort of keep, like you were saying before, to keep those patients anesthetized. And because we're not, you know, they don't routinely get an EEG or even a 4-lead EEG just for anesthetic purposes. It's something which was easily knowable that we don't know.
Yes.
But it could probably, and so even if you just cut the dosing in half, and you, again, half the dose over an entire 24 or 36 hours, that's a lot less propofol you've given them. And when it comes time to try to wake them up, it could probably be 4 hours later as opposed to 8 or 10 hours later.
Right.
So I think just the act of starting to use the EEG to gain the intuition, and we're working now with our ICU folks, our ICU fellows and staff to try to train them in using the EEG like I'm suggesting here.
Very good.